Hello everyone and welcome to our channel PhysioSaurus. So today we are going to learn about the pain, okay? And these are the 5 or 6 subheadings that we are going to discuss in this video, okay? So first we will talk about the introduction, as in what is pain and the gait control theory and all, okay? And then we will just move on to the structures which produces pain, okay? So there are 3 structures: joints, which includes your ligaments, then muscles, which includes your tendon and the fascia, and we will deal with what is trigger point in this section only, okay? And then we will talk about the neural structures, okay? And the third subheading is your referred pain, and then we will deal about the types of the referred pain, which is your radicular pain and the somatic pain, okay? And then we will learn about the clinical assessment of the referred pain, okay? Then we will talk about the pain syndromes. So there are 4-5 pain syndromes that we are going to deal in this video, okay? So first thing first, introduction. So pain are perceived through nociceptors. So the receptors for the pain is nociceptors, okay? And in this introduction section, you need to learn about the gait control theory, which I have already discussed, and you can find that video in my electrotherapy playlist, okay? Now, nociceptors are the receptors which are found within bone, cartilage, ligaments, muscle, tendons, fascia, bursa, and neural structures. So as you can see here, in fascia also there is nociceptors present, okay? And we will talk about the myofascial release, okay, in the next video, of course. So in that I'll just correlate all these topics with that video, okay? So nociceptors are found within bone, cartilage, ligaments, muscle, tendon, fascia, bursa, and neural structures. So any of these structures, let's say that these structures are damaged, then they will produce pain because the nociceptors which are found in these areas are stimulated, okay? So stimulation of these receptors produces pain, okay? Next point, nerve endings produces chemicals such as potassium ions, histamine, prostaglandins, etc. from the damaged tissue, okay? Damaged tissue can be your fascia, bursa, neural structures, it could be anything, alright? So the damaged tissue will release the chemicals which is your potassium ions, histamine, prostaglandins, etc. Okay? Now, nociceptors can be stimulated mechanically too. Okay, let's say that there is severe musculoskeletal injury due to trauma, or it could be due to anything, okay? So that means at that time the nociceptors can be stimulated mechanically also, okay? For example, in severe musculoskeletal injury, the nociceptive nerve endings of more than one structure are stimulated. So basically what happens in the severe musculoskeletal injury, more than one structure is damaged, okay? So let's say that the bone is also damaged, muscle is also damaged, let's say bursa is also damaged. So what's happening there is lots of nociceptors, nerve endings are getting stimulated at one time, okay? So therefore, more severe the injury is, that means more likely that more structures are damaged, which will produce more severe pain, okay? Again, next point, the longer the duration of pain, more likely of an individual to adopt the abnormal movement patterns and compensatory mechanisms. So pain should be treated very well, alright? Because if there is a longer duration of pain, then it is more likely that an individual which is suffering from a particular pain will adopt the abnormal movement patterns, okay? And you will also see compensatory mechanisms or the trick movements due to pain. So please don't forget about it, okay? So, and that will cause other structures to become damaged and painful, okay? Very, very important point. Now let's talk about the structures which produces pain, such as your joints, which includes your ligaments, muscles, which includes your tendon and the fascia, and the neural structures, okay? Now, first of all, let me give you an overview why pain assessment is very important. Why knowing about the structure which is damaged, which is causing the pain, is very important. So let's say that the patient is suffering from low back pain, okay, because of a small tear of annulus fibrosus. Alright. So at that time, the nociceptors stimulated by the mechanical effect of the tear and chemicals are released. Okay. So chemicals are also released and nociceptors are also stimulated because of tear of the annulus fibrosus, which is causing the low back pain. Okay. So that will lead to pain and inflammation, associated muscle spasm, fibrosis within the muscles, which will further increase the stimulation of the nociceptor nerve ending. Okay. And if the case is severe, then neural structures such as your dura mater will also be stimulated. Okay. Then pain and inflammation will persist for a longer period of time, which will lead to local fibrosis. Okay. Then again the nociceptors will be stimulated and it will cause the pain in muscle, joint and neural structure. So this is why assessment of pain is very important. Okay. Also, knowing about the structure which is causing the pain is very important. I hope I am making clear this to everyone. Okay. Now let's talk about the structures which produces pain. So first is joints. Okay. So joints has many nociceptors. Okay. And the nerve endings which is present around the joints, it can be stimulated chemically or mechanically. Okay. So if the nerve endings are stimulated chemically, it would be a result of inflammation. So let's say that there is an inflammation around a joint. Okay. So at that time the nerve endings will be stimulated. Or let's say that there is abnormality of the movement which will lead to excessive stretch or excessive load on the body. So at that time the nerve endings can be stimulated mechanically. Okay. So there are two ways through which the nerve endings can be stimulated. Okay. Now let's say that there is abnormal movement present. Okay. So it will lead to hypermobility or hypomobility or abnormal quality of movement. Okay. Now abnormality can be in physiological movement or accessory movement. Now I have already discussed this physiological movement and accessory movement in a particular video. You can find the video in the exercise therapy playlist. Okay. Or I will just try to add all the necessary links of my videos in the description box. Alright. So here you can just remember this one point, that abnormality can be present in the physiological movement or accessory movement. If you want to learn more, you can just watch that video. Okay. Now physiological movement are those movement that patient performs by themselves. Okay. But to achieve the full range of motion, accessory movement is very important. So okay. Now accessory motion are involuntary. That means they are not under your own control. Okay. And these are interarticular movement, basically gliding, rotating, rolling, etc. Compression and traction. There are 5 accessory motion. Okay. So it occurs in both spinal and peripheral joints during normal physiological motion. Okay. So if you guys are watching this video, then I am assuming that you guys are in either 3rd year or 4th year student. Okay. So I think these terms are already clear to you. Okay. So you already know what is gliding, rotating, rolling. You have already read it in Synthia Norkins or biomechanics, any books of biomechanics. Okay. These are the basic things. Okay. Now loss of accessory motion may cause pain, altered range of motion or abnormal range of motion. Okay. So this is why accessory motion and the physiological motion is very important. Okay. So assessment is very important to identify any abnormal movement, and restoration of normal movement is very important to treat the pain. So there is 2 important highlight. Okay. Now let's talk about the muscle. Okay. So muscle includes tendon and the fascia, which also has your nociceptive nerve endings. and I'll discuss about this fascia a lot more, okay, in the upcoming videos, okay. So damage of these structures can cause damage of other structures too, such as your joints. So let's say that tendon is damaged or fascia is damaged, so that could lead to damage of the particular joints. All right. Now, muscle spasm occurs to protect the underlying joints, and at that time when these structures are damaged, muscle around those area gets into spasmodic condition, and it occurs to protect the underlying joints. So it basically protects your joints around the certain area. Okay. Now, pain happening due to muscle, it can be due to joint injury, which will lead the muscle into muscle spasm. So basically muscle spasm is happening as a protective response. Okay. And let's say that pain and inflammation from joint injury persist. Okay. Then muscle spasm will also persist. All right. And the increase in muscle tension will lead to chemical and mechanical stimulation of the nociceptive nerve ending. Okay. So let's say that the pain and inflammation from the joint injury is persisting for a longer period of time. Okay. So at that time, muscle spasm will also be present there. Okay. And this increase in the muscle tension will lead to chemical and mechanical stimulation of nociceptive nerve endings. All right. So the patient will feel more pain. Okay. So chronic muscle tightness, abnormal movement or overuse may result in muscle tightness, okay, leading to inflammation and fibrosis. Okay. So you could also see inflammation and fibrosis of a particular muscle, which could be due to overuse or abnormal movement. All right. Lack of range of motion due to pain will stimulate more nociceptive nerve endings. Such a simple statement. Okay. Now, next point. Palpation of localized thickened areas within muscle tissue shows tenderness. Okay. And it also produces pain sometimes. Okay. And that area is known as trigger points. So here our term came, which is very important. Okay. So the treatment involves restoring the range of motion. Okay. So see, the treatment is totally based on what structure is damaged. Okay. So your exercise protocol will be according to that. Okay. Now this point specifically, palpation of the local thickened areas within the muscle tissue, it will show tenderness. Okay. And those tender areas will produce pain, and that area is known as your trigger point. And this trigger point is released through cupping, through dry needling, through myofascial release. There are lots of other techniques as well. Okay. Now let's talk about the trigger point in detail, although I will also talk about the trigger points when I'll discuss the dry needling specifically. Okay. So trigger points. What is trigger points? So it is basically a spot in a body which is painful on compression. So when you will compress the spot, it will cause referred pain. Okay. Referred pain, referred tenderness and motor dysfunction. Okay. Trigger points can be active or it can be latent. Okay. So active trigger point will cause the pain at rest. So when you will be at rest, even at that period of time, that trigger point will cause the pain. Okay. And it has referred pain, refer kind of pain. Okay. So the pain will be referring to the other areas as well. And on pressing, it will give you a local twitch response, which is known as contraction. So when you will just press the area, compress the area, it will produce a contraction. Okay. And latent trigger point doesn't refer pain and it doesn't gives contraction response. Okay. So these are the difference between the active trigger point and latent trigger point. Okay. Now, latent trigger points can be seen in muscle tightness or muscle weakness. Okay. Patient with active trigger point has persistent regional pain and sometimes it is worse in night. Okay. Symptoms involve muscle shortening and decreased range of motion. Okay. So here are some common examples of the trigger points. Okay. So this is your upper trapezius, sternocleidomastoid, supraspinatus, infraspinatus, quadratus lumborum, gluteal muscles, piriformis muscles. So these are the common site and the common muscle name. Okay. And if you want to know the exact site, you could just type it in Google and look at few pictures. Okay. What should be our treatment approach? So the treatment would be your cold and stretching. Modalities are used, soft tissue techniques such as your myofascial release. Okay. I'm gonna be making a video on this. Okay. Dry needling, I'm gonna be making a video on this one too. Okay. And the other techniques are your ischemic pressure, local anesthesia, injections. All right. Now let's discuss about the neural structures. Okay. So nociceptors are present which are stimulated chemically by local inflammation from surrounding injured structures, or mechanically either by direct trauma or by acute or prolonged stretching. Same statement. Okay. So the nociceptors which are present in the neural structures, it can be stimulated chemically by local inflammation, okay, from the injured structures, okay, or mechanically by either the direct trauma or by acute or prolonged stretching. For example, nerve impingement in PIVD, okay, protruded intervertebral disc causing radicular pain. Okay, so this was one common example. Now let's talk about this neural tension, which will come under the neural structures. Okay, neural structures. So increased neural tension when there is abnormal movement causing pain. So basically, whenever there will be a damage in the neural structure, the neural tension will increase. The tension in the neural structures will be increased. Okay, and that would be due to abnormal movement. Okay, and that will cause the pain. Okay. Now neural tests are done to assess the mobility of neural tissue in extremity and spinal cord. I have made a separate video on the special test in the orthopedics. In that video, I have added the name of all the special tests according to extremity and spinal canal also. Okay, so I have provided all the names of that. So you could just watch that video. That video is just a short. You can find that video in the orthopedics playlist. Okay, so next point, positive neural tension test shows poor mobility of neural tissue which is due to scar, tight muscles, ectopic bone growth, adhesion within nerves. Okay, so let's say that the nerve tension test is positive. So that would mean that the neural tissue has poor mobility. So that means that the range of motion will be decreased. Okay, and the cause for that could be scar, tight muscles, ectopic bone growth, or adhesion between the nerves. For example, ankle sprain and hamstring sprain damages the neural tissue as well as muscles and ligaments. So that would mean that the range of motion will be decreased. Okay, here are the names of few tests that we perform as a physiotherapist. So the first one is SLR test, slump test, neural Thomas test, and the upper limb tension test. There is also lower limb tension test. Okay, now when pain increases if tension is increased and decreases when tension is decreased, then abnormality of the neural structure is more likely to be present. So let's suppose that you performed the upper limb tension test on a patient and the pain increased when you increased the tension, or the pain decreased when you decreased the tension while performing the test. So at that time, it is an indication that abnormality of neural structure could be present. Alright. Now the next point, that is effect of the pain due to increased neural tension. Okay. So autonomic fibers are also affected by abnormal neural mechanics and increased tension, that is neural tension, and this is why the pain is produced. Okay. So now let's talk about the types of pain that is produced as a result of neurological tension or nerve tension. Okay. So the first one is referred pain. Okay. So in referred pain, pain is felt as if it is coming from a particular side. Okay. It can arise from the local structure, but it may be referred to that site from structure some distance away. So for an example, patient can feel a pain in the calf, but the source of that pain could be in the lumbar region. Alright. For example, phantom limb pain. Amputees who perceives pain or feels the pain in the amputated limb. Second example, pain which is felt at the neck or arm in patient with the angina. And the third one is dull hamstring ache. Now there are some common clinical presentations in that, and I'll just totally skip this part. So let's just move on to the radicular pain, which is a type of a referred pain. Before that, there is a particular note on this, that referred pain can be due to nerve root compression or it cannot be due to nerve root compression. Alright. So if there is nerve root compression, we will discuss about its example too. So the examples of the referred pain which are not due to nerve root compression is your dull hamstring ache. Alright. Now let's just move on to radicular pain. So radicular pain is a type of referred pain that is associated with the nerve root compression. Okay. And it is a type of sharp shooting pain. Okay. In this type of pain, neurological symptoms are also present, which is your paresthesia or your muscle weakness. So these are the neurological symptoms. Alright. Now, nerve root compression results in the pain in the distribution of the dermatome. Now, dermatome inspection is done to determine the level of nerve root compression. So this is why the dermatome inspection is very, very important. Okay. I'll just try to upload a video on the dermatome some other day. Okay. Now let's discuss this somatic pain. Somatic pain is again a type of a referred pain. Okay. In somatic pain, pain is felt in one area that origins from the another area without any neurological abnormality. So there is just one difference between somatic pain and the radicular pain, and that difference is in radicular pain, neurological symptoms are seen. Alright. Okay. Next point. Somatic referred pain can be in form of myofascial trigger points. Very, very important. Okay. Myofascial trigger points, or it could be from joints also. For example, pain in hamstring and buttocks may arise from pain sensitive structures of lumbar spine. Okay. So pain is arising from the lumbar spine, but it is felt in the area of hamstring and buttocks. Okay. For example, in cases of annulus fibrosis of IVD or apophyseal joints. So these are the examples. Second example is pain in the shoulder can originate from the structures in the cervical spine. Another one of the most important examples of the somatic pain. Okay. Again, one note in the somatic pain, it is possible to have pain at the site distant from the source without pain at the source itself. For example, as we have seen earlier, that the patient is perceiving pain in the shoulder which is originated from the cervical spine. Okay. So it is possible to have pain in the shoulder without having the pain in the source or cervical spine. Alright. Now, Somatic pain is a static, dull ache that is hard to localize. Alright. Local tenderness is also seen, may occur, okay, when the pain is referred from the another source. Pain refers from somatic structures, so it does not have a consistent distribution. Okay. So since pain refers from the somatic structures such as your joints, alright, or your myofascial regions, so it does not have a consistent distribution. But when we talked about the radicular pain, since it is a form of referred pain where there is nerve root compression, okay, and since dermatome was getting affected in that, so this is why there was a distribution of a pain, there was a proper distribution of the pain. All right, now let's talk about the assessment of the pain, which is very important. Okay, I have also discussed this assessment of the pain in the orthopedics assessment. You can find the video in the orthopedics playlist. Okay, so there is one scale which is used in the pain assessment, and that is your VAS scale. Okay, now features of the pain that suggest it is referred pain. What are the features that suggest the physiotherapist that it is a form of referred pain? Okay, so the first one is dull aching nature of pain, poorly localized, deep seated pain, movement from point to point, less local tenderness than expected, okay, long standing pain, and failure to respond to local treatment. All right, now the next point, your aim of the clinical assessment should be to reproduce the referred pain by stressing, that means to provide stress with the hands, or by pressing the site of source of pain. Okay, and it is done by the local palpation if the source of pain is muscle. So if the source of pain is muscle, then it is done by the local palpation using your fingers. Okay, and it is done by passive or active joint movement if the source of pain is joint. So these are the assessing methods. Okay, and it is done by increasing neural tension if the source is neural structures. So we have already discussed about the special tests or the neural tension tests. Okay, third point, any significant abnormality of the joints, muscle or neural structures at the site that is a possible source of the referred pain is noted down. All right, and the abnormality is treated, such as restoring range of motion, eliminating the active trigger points, or restoring the normal neural tension. Okay, and let's say that if the pain vanishes after treating the abnormality, then it is more likely that the treated area, the area on that you were treating, that area was contributing to the pain. Okay, so this was the assessment of the pain that is discussed in very short. All right, now let's talk about the pain syndromes. Okay, so it includes reflex sympathetic dystrophy, which is a old name. The new name for this is your complex regional pain syndrome type 1. In short form, it is written as CRPS type 1. Okay, it is again of two types, sympathetically maintained pain and sympathetically independent pain. Okay, the second syndrome is your causalgia, which is again your old name. The new name for causalgia is CRPS type 2. Okay, third one is your myofascial pain syndrome, and the fourth one is your fibromyalgia. Let's discuss this one by one. So the first one is CRPS type 1. Okay, so in CRPS type 1, there is pain, swelling, stiffness and discoloration of the extremity after any trauma or any disease. Okay, it is divided into sympathetically maintained pain and sympathetically independent pain. In sympathetically maintained pain, okay, there is pain and there is autonomic dysfunction. Okay, the function of the autonomic nervous system won't be proper, okay, and this pain or the symptoms is relieved by the sympathetic blockade, okay. In sympathetically independent pain, it is present even with the treatment, and other neuropathic mechanism is affected. Other means other than autonomic nervous system, all right. CRPS type 1 injury can be due to trauma to soft tissues, bones or nerves, or it can also be due to after surgery, okay. Predisposing factors can be genetic factor, okay. Now let's talk about the treatment. So treatment is your drugs and peripheral nerve stimulation, spinal cord nerve stimulation, and physiotherapy and exercise rehab, all right. Drugs includes corticosteroids, tricyclic antidepressants, sympathetic blockade, epidural opioids, local anesthesia, all right. Now let's talk about the causalgia, okay, or CRPS type 2, okay, type 2. Now in causalgia, there is a specific peripheral nerve injury and pain is due to injured nerve, okay. Associated symptoms can be present with autonomic dysfunction, all right. Now the third point, myofascial pain syndrome, okay. So in myofascial pain syndrome, there is local painful muscle disorder which is caused due to myofascial trigger points, and that is released by dry needling or MFR, okay, all these methods. The last one is your fibromyalgia, all right. So it is a generalized condition. It is not just particular about some location. It is a generalized condition. There is presence of multiple tender points, okay, in more than one location of the body, okay, such as pain above and below the waist and on both sides of the body, okay. So basically there are 18 designated tender points, okay, throughout a human body. So in order to have, or in order to mention that this patient is suffering from fibromyalgia, there should be at least 11 out of 18 designated tender points, all right. So this is a chart which shows the difference between the myofascial pain syndrome and the fibromyalgia. You could just take a screenshot of it. I'm not going to repeat this, okay. So this is it. The next video I'll talk about maybe MFR, okay. So thank you so much for watching this video.